Good morning. In this video, I will talk about syndesmosis injuries of the ankle. Syndesmosis injuries can be associated with both bone fractures and simple ankle sprains. A number of people continue to experience ankle pain even months after an ankle sprain. There are various causes for residual ankle pain, and unfortunately, they are not always recognized. I have therefore dedicated a video on this YouTube channel to the most common causes. This video in particular is dedicated to syndesmosis injuries. Ankle sprains can occur in two ways. The one in the photo on the right is called hypersupination, which is much more common, while the one in the photo on the left is called hyperpronation, much rarer. Syndesmosis injuries most typically occur with excessive pronation or external rotation. The syndesmosis is a joint formed by the end of the tibia, which you can see colored in yellow, and the fibula, which is colored in green. The stability of the syndesmosis is guaranteed not only by the shape of the bones, which fit together well, but also by the presence of a series of ligaments surrounding the joint. In the event of significant injury to the syndesmotic ligament complex, instability will occur, and therefore the possibility that these two bones, even if only by a few millimeters, may tend to move away from each other. This residual instability can be a source not only of pain, but also of swelling and a feeling of weakness in the ankle. The diagnosis is not always so easy. It is certainly necessary to have a thorough knowledge of the anatomy of the ankle and to understand that this pathology may be the cause of the symptoms. The best and most representative examination is high-power MRI, or MRI, with contrast medium injection, which is a magnetic resonance preceded by the injection of contrast medium into the joint. In some cases, it is also advisable to perform an infiltration with a small dose of cortisone and local anesthetic. This injection can certainly help to understand whether the pain comes from inside the joint or whether it has a cause outside the joint. In the case of syndesmosis injury, conservative treatment, such as physical therapy, is of little use, and in these cases, surgery is recommended, which can be performed under spinal or general anesthesia. The actual surgery can be performed with a longer incision in the skin or using arthroscopic technique, which is a minimally invasive technique. Arthroscopy is based on the use of a small fiber optic camera that is inserted into the joint through a small incision. The camera is connected to a monitor on which we can see directly and in real time what is happening inside the joint. In this first case, we have a patient with subtle instability, in other words, with a very slight instability. The first step of the surgery is to view the joint and begin to remove all the scar tissue we find. The photograph at the top right shows how the instruments are positioned. On one side is the camera, while on the other is the instrument we use for cleaning, which we call a shaver. Once the scar tissue adhesions have been cleaned, we can finally move on to the synthesis between the tibia and fibula. The purpose of the surgery is to stabilize this small but important joint by inserting one or two screws that will allow the ligaments to heal. At the top, you can see the tibia, while further down, you can see another bone called the talus. At the bottom left of the screen, I am using a hook to touch the syndesmosis. Normally, this cannot enter the joint so easily, and this is a clear sign that the joint is indeed unstable. Now I will show you the case of a young patient who had much more pronounced instability than the previous patient. As always, the first part of the surgery involves removing the adhesions in the joint that formed over the months when the joint was unstable. The patient continued to complain of pain, instability, and swelling after a sprain while playing soccer. We are faced with very significant instability in which there is a large scar at the level of the syndesmosis, which is the tissue I am cleaning now. Much of the operation was devoted to cleaning this tissue that had formed in the months following the trauma. I am now using an instrument called a shaver, which you can imagine as a kind of razor with an oscillating blade that cuts and simultaneously aspirates the scar tissue. This space between the two bones should not normally exist. It is therefore logical to think that the purpose of the operation is to bring together the tibia, which you can see on your right, and the fibula, which is not yet clearly visible and is located on the left. We finally reach the point where we can see the fibula in its articular portion, visible just behind the surgical instrument. At this point, the joint between the tibia and fibula has been brought closer together, but now we also have to stabilize it using screws, which can be either metal or, as used in this specific case, resorbable, which therefore will not need to be removed as they will resorb spontaneously over the 8 or 9 months following the operation. After the operation, a long boot brace is immediately fitted, which can be removed to begin physiotherapy. Your surgeon will tell you how much weight you can put on the ground. After the operation, you will certainly be prescribed prophylaxis with low molecular weight heparin to reduce the risk of deep vein thrombosis. As I mentioned earlier, your surgeon will tell you how much weight you can put on the operated ankle, but you will need to use 2 crutches for balance. To avoid swelling in your foot and ankle, you should not stand for too long. As a guideline, you can move around for 15 minutes every hour and then keep your foot elevated for 30 minutes. Remember that swelling can cause pain. Even when sitting, it is always best to keep your leg elevated, for example, using a stool. If your surgeon allows you to temporarily remove the brace, you can apply an ice pack locally for no more than 10 to 15 minutes, repeating this at least 3 times a day. Once you are discharged home, you will obviously have medical prescriptions, including painkillers, which I recommend you take even if you are not in pain, for the first 3 days only. After the first 72 hours, you can take painkillers only as needed. The skin sutures are generally absorbable and therefore do not need to be removed. In other words, they will fall out on their own. The only important thing is that these stitches are protected with bandages and a dressing for at least the first 2 weeks. This obviously means that you cannot get the dressing wet. If you really cannot give up showering, at least use waterproof bags that you can find at the pharmacy, perhaps reinforcing them further from top to bottom with cellophane, such as that one normally used in the kitchen. After the operation, your ankle will certainly be a little swollen and stiff, so it is unthinkable to return to driving immediately. Generally, the average time to return to driving is a minimum of 6 to 8 weeks. Physical therapy is certainly important after the operation. Your surgeon will tell you what to do and when to start. Generally, you can start after 2 weeks, with the aim not only of regaining mobility quickly, but also, and I would say above all, of reducing the residual swelling of the ankle. As with all surgical procedures, there are naturally some risks, including infection, which may require not only another surgery to remove the bacteria, but also antibiotic treatment that can last from a few weeks to a few months. Another risk is deep vein thrombosis, which has a low incidence provided that prophylaxis with low molecular weight heparin, in the form of small subcutaneous injections, is followed. Residual swelling of the ankle is almost certain to occur. The swelling can last from a few weeks to several months. Over time, the swelling will gradually improve, albeit slowly. Physiotherapy will certainly accelerate the process of reducing swelling. Along with the swelling, you will also notice a certain degree of residual stiffness in the ankle, but this will also tend to improve gradually over time and with physical therapy. Another complication to consider is the persistence of ankle stiffness and residual pain. This may be due to the failure of the ligament we are going to reconstruct to heal, but it may also be due to damage to the cartilage, which may lead to osteoarthritis over time. The likelihood of residual cartilage damage will obviously be higher in patients who have had a long-standing ligament injury with consequent instability for too long. If you think this video was helpful, or if you think it could be useful to someone else, please like and subscribe to the channel. Thank you.